And introduce your partner here.
Yeah, this is Dr. Garcia. She's a medical doctor. She owns her own surgical center here in the city. Is one of the best women's health doctors in the Southwest. She helps out with the fighters quite a bit. Sometimes we have stitches that we need done, and she's been gracious enough to help us with those and physicals as well. So, a medical school graduate, UNM?
UNM.
Yep.
Went to Chicago for a little while.
Yep.
And then came back home.
I missed it.
Welcome to the show, Doctor.
Red and green and Sandy Mountains.
Green chili.
So you're with a social media influencer. This guy, he's more famous for being a YouTube guy than being a doctor. So
true.
How cool is that?
It's true.
Am I doing it again with the mic?
You're good. We hear you.
All right, cool.
We hear you.
Yeah.
Loud and clear.
All right.
So
let's get into it.
Let's do it.
So did we land on the moon? That's the $1 million question.
Let's start this off just right. Did we land on the moon?
You tell me.
Let's take a poll.
In the cathedral
fire. Of course
fire.
we did.
Yeah, of course we did.
Was it a Hollywood basement?
I will vote agnostic.
Smart people know we landed on the.
I'll sit on the fence on that
Just
one.
because you're part of Mensa doesn't mean you're smarter than
I'll sit on the fence. So, in science, right, something has to be reproducible. So as soon as we do it again, then 100%. But I cannot verify that myself.
We did it more than once.
Exactly.
Under the Nixon administration.
Like 3 trips, 4 trips?
All under the Nixon administration.
So what's that got to do with it?
So if you trust Tricky Dick,
well, you did the right thing.
Yeah.
So what about Mars?
I said if you put a gun to my head, yeah, probably we landed. But I think it's also possible that maybe we sent rovers and you didn't actually get people on there. I mean, I don't know. There's certainly a rover up there, right?
Yes.
You can shoot a laser off of it. So there are certainly, yeah, I think there's rovers on the moon, Mars.
Didn't you watch Transformers?
Yeah.
I mean,
the Dark Side of the Moon one?
Yeah, we're landed on the moon, and there's a transformer.
I swear to God, if there's another Transformer movie.
Or the Bush Beans, what about the Bush Beans commercial?
The Bush Beans commercial? The dog?
No. He died. The dog.
Yeah, they tend to do that. R.I.P. Bush dog. I don't remember that.
It's a funny commercial where the space guys are hopping along the moon, and one of the astronauts, they're all hiding because this monster comes out of nowhere. And
I do not remember that one.
One of the guy farts because he was eating beans.
No, I don't have a television.
That's a Bush commercial?
You guys don't watch TV?
No.
No?
Yeah.
Interesting. Tell us about that.
It's the commercials. It drives me crazy.
Yeah.
Yeah, and then you get Bush Beans dogs, and then they die.
And then you get attached to the creature on TV, and then it dies. Or you start thinking that Jared's a cool guy, and then come to find out he's the sickest pedo ever. Like, nobody's ever what they seem like,
Yeah.
Okay, so let's get back to the space thing. You know we're getting ready to go to Mars, right?
Yeah, we'll see.
Are you going to believe that? I mean, what's it going to take to convince you that we're actually on Mars when that happens, or when the astronauts get on that ship, blast off?
Yeah, I don't know. I mean, I at this point, with the way CGI is, I guess people would question everything, right? So, I don't know. I just I'm agnostic.
You're a science guy, though.
And
so, I mean, you just don't believe. I mean,
well, science has nothing to do with believe, right?
Well,
that's faith-based.
There's a lot of scientists that are making this space flight happen.
And that's called an appeal to authority logical fallacy. So, for example, if you wanted to test gravity, you could do it over and over and over again. I could drop something repeatedly because the scientific method, right? You have a hypothesis, you test it to see if it's
do a poll,
true
Nick.
or not. So
Did
we
we
have a
go to
null
the moon or
hypothesis, and then you have to see if it's reproducible. And they're actually doing something called the reproducibility project right now, where I think they found something in the range of 30% of all the gold standards in medicine weren't actually reproducible. And there's a bias in medical journals in that way too, because they're not incentivized to reproduce a study that's already happened again. They want novel studies. And so we end up studying a whole bunch of crap that has no relevance whatsoever to actual medicine instead of retesting something to make sure that we have that it was right.
They're looking at me because I disagree. But we actually, no, there are a lot of times that studies are reproduced. And it's important. It's important to get the same kind of data, especially with policies or things that come up that are dramatically changing the way we've done things before. You want to make sure that data is real and good.
Right, 100%.
Yeah.
And so that's sort of the point, that science needs that reproducibility. I'm not saying they haven't done it. I'm saying really with this multi-million-dollar project that they have done, they have found that things that they used to find were gold standards are maybe not as accurate as we thought that they were. You'd have to pull up exactly which studies we were talking about. Because we say a beautiful theory does not a fact make. And some studies are really not reproducible, right? Like, so how would you, for example, reproduce a shoulder replacement surgery? I mean, it's going to be really hard to run a sham surgery because we have ethics. You can't just, we'll take that shoulder and we'll fill it up with balloons and we'll see how they do. There's no real way to test those, and it's sort of tricky in my field, especially because we're talking about pain. And pain is a very subjective, unique experience.
Yeah.
Everybody experiences it differently. So, how do you really quantify that? Well, you only get feedback, and that's sort of subjective to nocebo, placebo, interoperator error, suggestibility of the clinician, likability of the clinician. All those things tie into it. So, does something really work? I mean, there's a lot of questions to be asked about that. And of course, the truth is that we don't really know a whole lot about anything. We're talking about, penicillin being commercially available, 80 years ago. So it used to be that if you scratched your arm in the woods, you would die.
It's true.
Or if you got an upset stomach, you were going to die.
People were dying at 40 years old too.
I mean, so there's a little bit of misnomer there. So we were talking about this the other day when you talk about Social Security. In 1935, when FDR put in that deal for Social Security, the age of retirement is 65, right? So the age of life expectancy at that time was somewhere between 59 and 61. So the interesting idea behind retirement back then, and again, at that age, most jobs were like real jobs. You weren't doing computer work like you needed to actually be able to sweep or do something. So they needed some sort of protection in place for the elderly to be able to take care of them because they weren't really hireable because they couldn't do those jobs. Now, of course, life expectancy being up at 79 or 80, it sort of changes the game from there. But when you had that number at 61, 59, it wasn't because people were actually dying at that age, right? When you have a bunch of child deaths, that moves that number down drastically. So infant mortality was a major, major, major problem. It still is in the third world, by the way, as far as life expectancy. So it kind of changes the data. Like if you have two 100s on a test, for example, and you get a 0, then what's your average? It drastically drags that number down. So, lies, damn lies, and statistics. You can sort of make them say anything, and they don't really mean what you might think that they do.
So you're not depending on Social Security for your retirement. This is what you're saying.
Well, is it going to be there?
I think it's already broke as it is.
Well, when the government takes from that and spends it on other
borrowing
things.
it, yeah.
And then we have a smaller generation of people who are paying in less. Of course, it's not going to be there. I mean,
It won't be there.
So.
So you got a whole separate savings account, is what you're saying.
I'm trying to. If Uncle Seb wouldn't take 30.
Let's talk about taxes. Did you get your taxes in on time?
Oh my God!
How much
got
you owe?
murdered. How about you, Doc? You got murdered too?
I filed an extension.
Yeah.
You got till August, right?
So we're always complaining. Tell them about the gross receipts thing in New Mexico. This has to be fixed.
This is a crazy thing for a physician. So, for some reason, other professional fields don't have to pay gross receipts. If you're a plumber and you come to my house and you give me a bill at the end of your work, you tack on the gross receipts, and I, as the consumer, pay the gross receipts.
Yeah.
You take what I pay, and then you'll eventually then pay that back to the the city.
If you're doing it right, yeah.
If you're doing it right. So in medicine, the physician has the onus of paying the gross receipts.
So you have to pay my bill,
I
my taxes.
I pay your gross receipts.
Wow. Just for doctors.
Just for doctors. Isn't that nice?
And you already have like high insurance and
crazy insurance.
Malpractice.
Yeah, do you know how much I pay in malpractice for gynecology? $42,000. If I were practicing,
was that a year?
That's a year.
A year.
42,000.
Yeah.
Wow.
Isn't that the average salary of
The average salary
of an American?
for family income? I mean,
That's just above
person in
That's
family.
just your malpractice.
That's just above the median income of New Mexico.
Yeah.
If I were doing obstetrics, it would be probably 65.
Holy crap.
And that's good in places like,
East Coast.
Pennsylvania, East
Yeah,
Coast,
East Coast.
$250,000.
Oh my God.
To help people.
Right. It's you
Yeah.
can sort of see
Insane.
where the inflation comes into the cost of healthcare, and then it always ends up back on the consumer eventually. Or the physicians are run out of healthcare, where they end up in a hospital system and they can't have their own practice anymore. And that's sort of what's been going on. You wanna elaborate
So
on
you're
that?
not doing it for the money, is what you're saying. You're not doing your job for the money.
Well, everybody wants to make a living, right? But to do it for the money, it's too hard.
Yeah.
Yeah, it's not. You probably make more money making a podcast.
Well, not our podcast, but
Yeah, your overhead when you're paying for MAs and you have liability insurance and all that other kind of stuff. So I think what's interesting too. So I pass the cost back on to the consumer.
I was going to say, as a chiropractor, how what's the difference?
Well, the difference is I'm not contracted with insurance companies, so I'm not breaking my contract with an insurance company by charging that. So I think that's what you had told me before.
Yeah, that's right.
Like,
so basically, I contract with an insurance company to get reimbursed a particular amount, and they are saying you cannot collect gross receipts from patients.
Man, I'm learning a lot right now.
There was a little bit that
$40,000.
changed several years ago. The state said, okay, so you cannot pay gross receipts on anything that you receive from the insurance company. So that's my contract with the insurance company. But there's co-pays, there's co-insurance, there's deductibles that we're having to collect from patients. So all of that is still subject to 7.875% that I have to pay.
So you practice, you have an office here in town locally. Are you taking new patients? I mean, can people call you and set up with you? How does that work? I mean,
How does that work?
you're pretty booked up?
Pretty booked up.
Okay, yeah.
But good, always available.
Because
You can find me.
people are watching, they're going to say, I want that. That doctor seems cool.
Yeah,
She's
she's cool.
awesome.
She knows what she's talking about. She's the best in the
But
Southwest.
that's why you can't take new patients, because you're so busy already.
Yeah, so
It's a good thing.
right now they can find me at Southwest Women's Health.
Okay.
Yeah.
Yep.
Well, that's good.
And one of the sharpest minds too, a real thinker. We talk about this a lot when we discuss, evidence-based medicine and what that means. And when you look at the backbone of evidence-based medicine, really there's a Venn diagram that sort of sums it up. And it talks about the literatures in one portion, you have clinical expertise in another, and you have patient input or patient willingness in the other. So to have the best quality care, you need all three parts. And unfortunately, I think, and I don't know if this goes one way or the other, but I think I have a theory that even the college experience sort of tends to make you not be able to problem solve on your own, because you're always asking for the teacher to come help you and give you rules. There's always rules and regulations. So it's rare when you find somebody that's a professional that's been through all of the academia, that thinks for themselves, that problem solves and says, hey, I'm aware of the literature, but I'm also aware of outliers. You're also aware of statistical variation, and say, hey, I'm going to put my patient first. Because when we talk about this, and we've said this before previously, like epidemiologists and clinicians are fundamentally at odds with the way they look at the world. If you're an insurance statistician or epidemiologist, if you're a public health official, your job is sort of to ignore the individual. You're supposed to look at the first and second derivative. And as a physician or a clinician, your job is to take care of the individual in front of you, even if they don't fit into that guideline. So they may fall outside of what you would normally do guideline-wise, but that's why you need that clinical expertise, which, by the way, you cannot have without years of experience and actually seeing real cases in front of you. So brand new, there's a reason why there's residencies. There's a reason why you need to get out in the field and you need a mentor in the field, because there's no way that you're going to be able to have that expertise, and you'll steer people the wrong direction.
Yeah, you need a mentor. It's what we're lacking in medicine today, is that person with all that experience that says, let me show you.
Well, I
right?
guess that's kind of hard, because I mean, most people that want like you to be their mentor, for example, they're going to go to school, maybe here at UNM for a while, but then they're going to end up having to do their residency somewhere completely different. So I mean, how unless they're long distance calls all day with you, I mean, how would they be? How would you be a mentor to these people?
You know, people find me all the time. So I've got high school kids that are interested in medicine. They want to come watch. I've pre-med students, residents, even physicians. I've had a program in the past where physicians will come to my office and watch procedures, and then I teach them all about things. And then I actually travel to other places to teach other surgeons how to do surgery.
That's
So I'm
awesome.
pretty accessible, and I do the same. I travel all over the world watching my colleagues do surgery. There are a whole lot of right ways to do it and a whole lot of wrong ways. So ideally, even at this stage of the game, I'm up for learning other right ways to do things.
That's amazing.
That actually makes sense, because I mean, like, the way they do things here in the United States isn't necessarily the way they do it in Germany.
Absolutely, yeah.
They also don't have the high medical malpractice insurance rates and all that kind of stuff. They don't have to worry about that. So I mean, I bet you talk to them and say, man, have you ever considered moving abroad just to avoid these kinds of things?
I have, but there's always a trade-off, right? Here, I'm a woman surgeon in charge of my life, total autonomy. I own a business, I own a home. I'm in a lesbian relationship, and these are things hard to find in other places. So I'm super grateful for my education, the life that I have here, and I'm definitely also down for other experiences of other cultures and other places that I can just bring back and have my life, here and bring that back to the medicine that I practice.
How many other women gynecologists are practicing here in Albuquerque? Do you know? Is it a lot? It doesn't seem like it's a big number.
How many of the gynecologists in town are women?
Yes.
There's probably 45 or
So
so
that's
gynecologists, and more than half.
That's actually more than what I thought. So I mean,
There's the university, and then Presbyterian has a bunch of employee physicians in the Lovelace system, the Vita system, and then private practice. There are a few.
So the
There are a
better
few
question is how
private
many
practice
private
doctors,
practices
yeah.
are there? It's pretty.
so private
There are not
practice.
many.
They're being
because
chased out.
Yeah, it's really just too difficult for
Yeah.
any field to stay in private practice, and it's the insurance companies that are driving us out, which is really too bad because my generation, when I'm gone, the younger generation isn't coming out of residency saying, I want to hang my shingle and I want to go do this on my own. No, people coming out of residency say, give me an employed position where I can work 9 to 5.
So
Because, yeah.
So without getting political, under which administration did you notice that the insurance was just getting ridiculous?
You know what? I will talk about it and be political. I'm a huge Obama fan. I think that the idea behind a universal single-payer health system is a right idea.
So you're for Obamacare is what we're
Well,
saying?
no. The concept of everyone deserves quality of life and health, right? That the single-payer system is a way to begin to provide for many, many, many more Americans. And that is exactly what happened. All of a sudden, now you've got 30 million more people receiving health care. So what it did to physicians in private practice is essentially, I'll just give you an example. So let's say my practice is commercial payers, let's say 75%. And then 15% is just in my patient population, Medicare. And then I saw very few Medicaid patients because it's just not the age group of women that I tend to take care of. Most women that I see are having surgery, they're older, and women on Medicaid tended to be more of the reproductive age. There's a lot of great social services for that age group. With Obamacare, now so many more women have access to care, which is absolutely right. But now, if I lose 7% off of every Medicaid and Medicare patient that I see, I can balance that with the commercial plans, and I'm fine, and I'm comfortable, and I'm knowing that that's the service that I'm providing. But now, if 50% of my practice is reimbursed at those lower rates, there's no way to keep the doors open. It's still a business. I think as a physician, I still have the right to be a business owner and not make a huge profit, but to pay my employees and to have health care of my own. And that's what Obamacare did to the private practice physician. Unfortunately, it was a side effect. And do I still believe that everyone deserves health care? Absolutely. Did I likely, lose my practice because of it? Absolutely.
Right. And I agree. That's certainly a byproduct of it because, in a way, Obamacare was like designed to fail. Sort of, it sort of weaponized the pharmaceutical industry and the hospitals because they're sort of exempt from everything. Like we were talking about before, the hospitals, if you're in that system, you're exempt from that gross receipts portion. If you're in private practice, you don't have that luxury. And so what you're seeing now is there is a gap that's being filled by hospitals, administrations, big groups because they can handle it because they make it up in big numbers, and because the physicians are salaried now, so there was really no incentive to do more or less, and they're really being pushed hard as far as clinical numbers. They have to see X amount of patients a day. What you're seeing is less face-to-face time between the physician and the patient, which leads to poorer care, which means to more mistakes, which means to more follow-up care, which gets way more expensive in the end. And that's, so what we have to do, in my opinion, is we have to figure out a way to reverse engineer that part of it. Whether it's getting more physicians in the field, whether it's training nurse practitioners to be better, whether it's getting rid of tuition for medical doctors, whether it's not capping the medical school classes. Because, many family physicians retired once this... And the EMR thing was another one that pushed a lot of older physicians out. They really struggled with that.
Yeah, it's a time consumption monster. It is
doesn't
stealing the life from physicians. 300 physician suicides a year last year.
Wow.
It's very, very
It's
high.
too much. The demand for our time, and then you come along. If you're an insurance company and you say,
And they
you need to
fight
see.
you on everything too.
Oh, you need to see more patients with less time, and you need to do a better job, and to do that to a physician. Physicians, we go into this field because we care about patients, and we can't stand not to do a good job.
Right.
So then the insurance company knows this, or the hospital who's employing physicians, because what we do then is we take all of those things that we have to do, and we do it on our own time.
Mm-hmm.
And we stay up till midnight, 2 o'clock in the morning, and we don't see our families, and we're depressed. And then you come along, and then there's a bad outcome.
Sure.
And we take it so personally because no one ever wants to make a mistake and have a bad outcome. It's just the tremendous changes on physicians, and exactly what Bo said is happening is that we're losing physicians, and it's because the demands of the EMRs, the demands of the hospital. It's all about money, and physicians are all about helping people. And there's this dichotomy, and we're not making it. We're a dying breed.
It's interesting. So are they keeping numbers about physician suicides internally that you guys hear about? Because that's not stuff that normally we hear about. Is that just something that
I'm not sure there's, because of doctors' positions in society, I'm not sure it's as emotional an issue as veterans or somebody like that, unfortunately. Because people view attorneys, physicians, people like that in such a high light. There's not a lot of public empathy, in my opinion. And so I think the media and those people know that, and that they're not trying to cater to that audience because they sort of view them as the elite.
Yeah.
That's my opinion. But kind of talking about what we were saying before, because I agree, and I think this is very tricky, and I think that, I'm a free market capitalist in almost everything, but there's a couple areas where I don't think that should be, and that's, of course, education and healthcare. Those are things that are supposed to make society better. So something has to change, and it might be that it's a single payer. It might be that we need more competition. Because we know that we are animals, and we do respond to stimuli. We need we need sticks and carrots. Like, if you think about your dog, it didn't learn to roll over or learn a trick because it was a nice boy, a nice dog. It did that because it offered a reward. And so when you're not allowing physicians to have rewards, you're not allowing all these things to have rewards, well, you're going to get kind of mediocre performance. And I think that's what happens, not intentionally, but as a byproduct to a lot of salaried worker bees. And I say the same with pharmacists that are stuck at CVS and all these other places. They're basically corporate employees, and they're forced to sit there during these hours. And even the creative side we were talking about, there's not a lot of leeway to do what they want necessarily. They're pressured by admin to do X amount of procedures, or we don't do this because insurance won't pay for it, or the risk benefit, in the opinion of somebody who never saw the patient, says no, and that's the insurance thing we were talking about. So say she wants to write a prescription for a patient she knows needs that. She writes that prescription, the patient takes it to the pharmacy, they run it up, and the insurance denies it. Some physician that never has seen this patient says, oh no, based on the clinical guidelines, they don't need that.
Actually, if it were a physician, it would be, then we could have a conversation. But it's not. It's actually,
or an admin, or
it's some other person in a role of
saying no
without any clinical understanding of what they're saying no to. As an example, my wife is an endocrinologist, so she takes care of diabetics.
So they have 2 doctors in one house.
Yeah.
I was going to say, that's a lot of malpractice insurance.
Yeah. Well, hers isn't so much. But, she, first of all,
mine is $1,500 a year.
And you're doing all that cracking.
Wow.
I don't even crack.
And he's getting rich. He's getting rich off YouTube. We'll talk about that later. But
so she cannot get, number one, insulin. Insulin is like the life-saving drug that should be 2 cents. Is so expensive that these people with diabetes and really good health insurance, and they're paying thousands of dollars a month, still can't get their
or they're
their
trying to
insulin.
ration it and then they end up dying.
Yeah, they ration it, and so then they end up in the ER and getting admitted to the hospital.
That blows my mind.
And so
if I could set up,
I'm sorry. She wants to get basically a machine that goes under the skin and tells the patient what their glucose is, what their blood sugar is at any moment.
Wow.
It's continuous, and it saves lives because.
And does that release it too? Is that one of those synthetic?
And they can get a pump.
Yeah.
They can get a pump so these 2 sensors are communicating. the reason the continuous glucose monitor is so important is that diabetics go low, and they go low at night, and they drop their blood sugar so low that they will seize and die if no one is around them.
Wow.
And so the monitor has an alarm. And so there are a lot of really good things. But the insurance company just flat out denies it, confuses that with the little monitor that you know, pick your finger and it
Yeah, the
tells you
old
your blood
school
sugar.
way,
Touch.
The old school way. So they're saying, no, you can't have that. Use the other one.
Use the fancy one, the
So-
expensive.
It's just an example, but you know, someone is up there making decisions, and if a physician had called to speak and say, hey, this is why we won't approve it, then there's that opportunity for an interaction from another physician. They say, this is what my patient needs, and this is, that person can't know endocrinology as well as the
Right.
endocrinologist.
Who
They
knows the
can't know-
patient also, by the way.
And then know the patient.
Even if it was just another endocrinologist, again, the clinical expertise of knowing the patient. Like, two endocrinologists aren't the same if one actually knows the patient. It's
You know,
Yeah.
it's interesting because my dad was a pharmacist for over 36 years, and he would talk about this kind of stuff that you're talking about with
and then they're stuck in the middle, right?
and he's stuck in the middle.
Stuck.
Exactly. I mean,
It's a terrible position to be in.
Yeah, and he would get so frustrated there at the end of his career because it wasn't like that for his first
Right.
20 years. It
Because
was
you
it
used
was
to
simple.
trust the physician
Yeah,
who that's
exactly.
what they do to be able to make the decisions.
And even pharmacists'
you know?
insurance rates went way up because they're held liable if they accidentally give too many of something or too much or the wrong. I don't even know how you guys keep track of all
And
these,
so
these names.
Let me give you an anecdote, man. This is pretty bad. So this is me personally. So, you know, I took a broad spectrum antibiotic for a chest infection in about 2012. As a result, developed ulcerative colitis pretty soon afterwards. Probably not C. diff, but some sort of bacterial spread.
Speak English, man.
So C. diff, Clostridium difficile, is a form of bacteria that
We
can
got a
cause,
layman in the room.
sorry. It can cause, you know,
Come on,
bloody
man.
bowel movements, anemia. It does pain, obviously. You know, 40, 50, 60 bowel movements a day. Problems with electrolytes, which can lead to, you know, heart dysfunction and kidney dysfunction and things of that nature. Went on longer than I needed to. Finally went and saw the GI. They got me on mesalamine, which is a medication for that. And most of the symptoms are under control. So I have to go in every 2 years to get a colonoscopy, which, by the way, I pay $450 a month for myself for insurance. And every time I get a colonoscopy, I still have to pay $1,500 out of pocket for that procedure. So the last time that I had gone in, instead of being severe, I was down to mild to moderate because the medication had been working like we expected it to, along with lifestyle changes and things like that. So because of that change in diagnosis, the algorithm that takes into effect which medications you should be taking or not taking, as my new insurance kicked in January, they said, oh, you can't have this anymore, basically. Even though my physician had prescribed it, it had been working for 4 or 5 years. So I said, okay, what's the cash pay rate? And they said $1,200 for a month's supply of anti-inflammatory medication. So I said, okay, let me wait. You know, I'm doing all right. Let me call over there. So you call the MAs. The MAs try to call back over, and you trust that something is happening in the system. Well, nothing is happening. You know, 2 weeks go by, my symptoms start to get bad again because this is a medication that I need to be on.
And you knew that was the medication that you needed
Yeah.
to be on. Okay.
Yeah, 100%. Because you know why? Because it had been working. So
Exactly.
results matter, right? But because of that diagnosis, they said I needed a lesser medication, essentially, because it was working, because
So
it was doing what it was supposed to
He had
do.
to have a flare
And
in order for them
I
to.
want to talk about that too in a
Yeah.
minute too when you get done. Yeah.
Right.
It's-
And so I ended up having the first time I didn't even have to go on prednisone, you know. So this time I had the prednisone from before. I had to take it just to keep me from falling apart. Ended up breaking down and paying $1,200 for the month of medication. But how many people have that capability? Not very many people have $1,200 sitting around. And think about what it must cost to produce $1,200 of the medication. So and that's the secondary portion, right? I'm the part that's supposed to be paying for other people, right? I'm 35. I'm generally pretty healthy. I'm a 6-figure earner. So I'm the person that's actually supposed to be paying for the Medicaid population and the Obamacare population, but I don't even cover myself. If you think that it's $1,200 cash, the insurance probably negotiates a rate of, I don't know, $600-$700 for that. And if I'm only paying $450 a month, I don't even get close to paying for myself. So that's kind of coming from our tax dollars anyway. So in a way, we already sort of are single payer. Now that brings up another point, I think, that when you look at inflation of what things cost and have cost over the last 30 years, you can see a very distinct linear growth up and down between actual capitalism and crony capitalism. And when I say crony capitalism, I'm talking about separating the consumer from the actual price of the product. And in healthcare, that is the price of the product. Same in education. So what has drastically gone down 200%? Cell phones, TVs. In fact, relative to inflation, fast food, gasoline. Gasoline has actually decreased in price by 200% relative to inflation. And that's because there's competition for those things. Gasoline's got some government intervention
gasoline,
too.
I don't know about that.
But the point is that the Saudis pump it out and it keeps the price down. So regardless, but what we've seen because of actual insurance, insurance itself is sort of a scam if you think about what that is. Insurance, by its very nature, like a casino, they will always make a profit on it, always. So think about your car insurance rates. Like if you use it, it goes up, and so if your health insurance doesn't go up, it goes up across the board. So we've created the system that separates me from the cost. So say I have a surgery, it costs $22,000. Maybe I'm stuck with $5,000 or $6,000. If I knew that it was going to be $23,000, I would probably shop around a little bit more. But it got to this point already to where we can't go backwards on it, and that's sort of a problem. Education's the same thing. These colleges, USC, $75,000 a year for undergrad. I mean, that's how could somebody get out of that? But because an 18-year-old is separated from that actual real price, they say, okay, I'll get out and I'll make six figures. So we've created a government intervention, a cronyism to a certain extent. And the same thing with patents and medicine, like insulin, all these other things. And true capitalism, you'd say, hey, that insulin's nice. I bet I can make that for cheaper and better. And in order to stay in business, somebody else would have to beat you to that. It's like chicken nuggets. How could you possibly get 10 chicken nuggets for 99 cents? It doesn't make any sense. You have to pay for your business, your employees, your workman's comp. You actually have to pay for the product. You have to ship it across the country. So, I mean, that doesn't even make any sense. And through capitalism, if you don't, I mean, nobody's going to stay in business charging $15 for 10 nuggets, right? Yeah. So that sort of drives the price down. So in a way, I think that the single payer could work as long as they were competing for a contract. The government said, hey, here's what we're going to do. There's going to be one contract for insulin or one contract for a hip replacement or whatever that is. You guys get to compete. And whoever has the cheapest and the best product gets the contract, and that's all there is for this year. So if you want to stay in business, you're going to have to do your best to get this price down. Instead, we see people like the Pharma Bro or whoever else that they buy a patent up for a specific medication, and they go, people have to have this to live, so I'll jack the price up. And guess what? People die, people go bankrupt. And when they go bankrupt, do you think the banks just take that on the chin? No, they pass that cost right back onto the rest of us, or we bail them out because they're too big to fail.
Insurance
set up for failure,
well,
like you were saying.
Insurance and pharmaceuticals are out of control.
They're out of control.
It's ridiculous. I mean,
this is what people need to understand about the insurance companies and the pharmaceuticals. They're thieves.
Big time.
Yeah.
We all agree there.
To the point.
Oh, yeah. If you didn't know that.
We'll vote on that one.
So enter the pharmacy benefits managers, right? It's just another level of administration to take money out of where it needs to be, which is direct patient care. So a pharmacy benefits manager is someone, let's say I'm the hospital, let's say I'm Presbyterian Healthcare, and I'm going to work with a pharmacy benefits manager. That means now that third party is navigating all of the medications that my covered lives are navigating, right? So you need insulin, you're going to go through that pharmacy benefits manager. But guess what happens? This pharmacy benefits manager gives a kickback to me as Presbyterian for all of the patients that are using insulin.
Yep.
They're going to charge $1,200 to the patient,
Wow.
and then I'm going to get $600 back.
That was kind of the stuff that my dad would talk about. Yeah.
And that's $600 to the pharmacy benefits manager. So in the end, it's the benefits managers and the hospitals which are making the money, and we're paying for it as consumers.
This is a funny.
Or the ortho device makers, or it's like this is a surgical screw. So unlike a regular screw, this one's $10,000.
You were talking about that medicine that you knew worked on you.
Sure.
Here's a personal story that I can talk about. Every other year I get this weird cough that comes up, and I just cough and cough and cough and cough. Years passed, I always got this stuff called Tussinex. It worked. It made the stuff go away. Apparently, it's a narcotic.
You know how you know you're a minority? Because you take Tussin for everything. Tussin. Got some problems with peroxide? Tussin gets paper rub.
But the stuff, Tussinex was
and Price is Right.
That's my grandpa. It's like, put some peroxide on it, though.
He'll be good.
Yeah, but doctors started saying,
Some
no, we
Tussin.
can't give you that anymore because it's we got to give you this.
Why? It's the best thing for a cough. It's codeine.
Right.
Exactly, and that's what I would tell them. No, we got to give you this other stuff, and it's not the same. And I said, no, it doesn't work. So sure enough, this last year I didn't ask for it because I knew they wouldn't give it to me, and I freaking coughed so much that I collapsed in my kitchen and went to the hospital for 2 days because I couldn't breathe. I coughed so much that I gave myself some weird rupture in my
Ruptured a lung?
Yeah, something happened. It was horrible, all because of this Tussinex that I used to take. They wouldn't let me take it anymore because they wanted to give me some weird stuff that doesn't work, and I knew it didn't work, and it's a pain in the freaking ass. It goes back to your story.
Yeah.
You know what works. We know what works on our bodies.
And we have to be careful, too, because we get these public outrages about certain things. So she's going to probably expand on this a little bit, like opiates right now, right? We go on and on and on about this opiate crisis, and there is a crisis. I'm not going to say that there isn't. But, the way we're addressing it, in my opinion, isn't the right way to do it. I think that so we sit in this opiate overdose meeting, and they're like, hey, listen, prescription overdoses are down. Okay, well, illicit overdoses are up. So that's a net neutral. But what have we really done, right? Like, you're pushing people because physicians are being constrained, and you can probably expand on this a little bit more. There are people that need opiates. So they are useful medication. Every medication has its place. The key is not to overuse or underuse.
I agree. I think agree that there is an epidemic, and it's sad. I think young adults kids are losing their lives to addiction, and so I don't want to downplay that at all. The other side of opiates is that they do work, and they're not only for acute pain, but also for chronic pain. When someone who uses a narcotic to address pain issues, if they become functional with the narcotic, that is working, and that's a right use for it. And those are not likely going to be the people who are ending up with overdoses.
Yeah, it's not like I'm using it every day. It's just every other year I get this stupid cough, and I don't. But
not even. I mean, that's fine. But we're talking about even people with chronic pain using opiates every day. So what's happening with so many restrictions is that physicians now we're afraid now to use the right medication.
That's
so
scary.
Much so
that is
that
scary.
a very personal friend of mine had melanoma in the eye and had radiation, these pellets that emanated radiation physically put into the eye to destroy the melanoma. Painful as heck. They actually admitted her to the hospital in order to manage her pain.
To keep her on morphine drip or something.
Ideally.
Yeah.
And yet they were so restrictive with the pain medication. She is crying, and had she not had my wife, there to advocate on her behalf, then she doesn't get what she needs. And so that's what we are doing now. We're taking it out on the patient that somehow the patient needs to navigate acute physical pain without pain relief. And it's cruel, and it's wrong.
And that's when you're going to see an increase in suicides too, by the way. Like, when people have this debilitating pain that they can't manage, they can't go on anymore. So
they have nowhere to turn.
Right. Now I'm in a pain management sort of practice, right? So I can kind of give you a perspective on my clinical expertise, at least. I've got about 10, 11,000 patients here in Albuquerque. Now, keep in mind, I have a biased patient population, right? I have a cash pay patient, so they're going to be a little bit...
10 or 11 patients? What?
10 or 11,000.
1,000. I was going to say...
So I have a healthier population. The people that are coming to me are willing to invest, and, they always talk about... you never wash a rental car, right? So you have to have some sort of skin in the game, and that's why I like this. When I've worked in family practices before, when I've dealt with Medicaid and, TRICARE and stuff like that, I find the adherence to our exercise programs was nowhere near as good as it was. And I'm dealing with a healthier population now, too.
Yeah.
So I have a couple different lenses to compare those two. So in my current position, the percentage of people that really need opiates is very, very low. Probably less than 5% of my patients need opiates. They can be useful in the short term for some of the guys that have acute. But if somebody's at the point where they need chronic opiate use, they probably don't belong in my practice. They belong in pain management or, neurology or something like that. So we try to get them out and get them where they need to go. Now, that being said, when I was in a family practice, that number was significantly higher. Probably 15% or so of the people that would come to me first, we would sort of make the decision, me and the physician that was over me, we would make that decision that these people need to be on these medications. And so, it's somewhere in those ranges that we're dealing with now. So what are the important things? I think we have to change culture, right? Like, parents need to talk to their children about these types of medications. It's not fun and games. It's not something to try out or whatever else, because it can cost you lives. And unfortunately, that culture of abuse, and these are, we're humans, right? We can become addicted. So it's important that they know that you don't try these things. But because of that, what we're seeing is a surge in the amount of physicians that, again, are scared to prescribe those medications, or they have limits to how many they can prescribe, or they're held liable for those prescriptions. And it's like, at the end of the day, like, you're running a, if you're in a hospital and you're running a patient through every 5 minutes, and a patient says they need a medication, and you give it to them, and then they say they're taking, I don't know, oxy, but then they also go take heroin and they overdose. Is that your fault?
I was gonna say, the overdoses aren't necessarily happening because of the pills.
Right.
It's
the other
it's
stuff
the
that
heroin.
that they're not talking about.
It's the heroin.
Or mixing medications.
Do you think that's self-medication because of the pain, or it's just...
I do think that there is probably a nidus or an inciting event which can come from pain pills. They go on too long. They like the way they feel. It elevates so much, right?
Sure.
And it's the euphoria that they're seeking, and it goes from pills to heroin.
People kind of get acclimated to pain pills after a while too, I think.
Well, and they're no joke.
Stronger. Well, I know that. Yeah, they
Which is exactly why the deaths occur,
Yeah.
is because this the body gets essentially accustomed to the medication.
You start taking more and more
It's
and
more and more and more, and then people decide, I'm not going to do it anymore. So they walk away, and they come back, and they start at the dose that they were on before they walked
Right.
away, and it's just too
Wow.
much. And
Look what happened to Prince or Michael Jackson. I mean, that they were over. They taking too much of.
well, Michael Jackson, that was a whole different different scenario.
Well, and
But it was stuff that he'd been taking for whatever reason, and he just kept wanting more and more and more. And they found a doctor that would just give more and more and more.
Well, it's interesting too when we talk about our culture of drugs. Is our drug schedule, the war on drugs has failed miserably, right? So that's not working, obviously. There's a million reasons for that. Some of them have to do with CIA involvement with cartels. Some of them have to do with for-profit prison systems. Some of them have to do with blatant misunderstanding of what actually these things do. I mean, by definition, Schedule 1 means that it's harmful, meaning a high potential for addiction and death, and has no medical benefits whatsoever. So you're going to tell me that mushrooms are a Schedule 1? Or LSD or MDMA, and then Dr. Strasberg at UNM has done amazing studies on those things for people with PTSD and terminal illnesses and being able to deal with those things. And they really, you're going to struggle to be able to link any specific death to any of those psychoactive substances. So some drugs will kill you. Like, good luck finding deaths attributable to marijuana. Now, there are other issues, potentially. We don't know if they're cause or effect or they're just association, like potentially schizophrenia in people that are exposed to it in young ages. Is it that the people that are schizophrenic are more likely to be adventure-seeking and try those medications? We don't know. But what you do see is specific deaths in certain ones, and those would be the downers, the opiates, because they they affect your lower brain, and they can make you stop breathing. Like, as bad as cocaine is, you're very rarely going to see deaths due to just cocaine.
Heart attack.
Typically underlying symptoms. But you see heart attacks across the general population. What is the rate of heart attack deaths pooping? It's astronomical. I mean, in a numerical population.
Why would you know that statistic?
Because you got to look up the rate of stroke and heart attacks, whether it's pooping, whether it's here's the real reason, right? Because we do
Elvis.
this post hoc ergo propter hoc logical fallacy, particularly with the cracking, like we were talking about, and this has been studied ad nauseum. So every time that there is a temporal association between somebody getting their neck cracked and a paralysis or a death, everybody assumes causation, and that's not how science works. Through all these meta-analyses that they've done through the literature, if you combine all of them together, you're looking at roughly 1 in 3 million people have some sort of association or traumatic problem with cervical manipulation. So that data is about the same as jiu-jitsu or yoga or sneezing or roller coasters. If you Google roller coaster stroke, you're going to find cases of people that stroked out on the roller coaster. Same thing with sneezing. Same thing with yoga, doing yoga poses. There are astronomically small numbers, and you have to ask, why do those things happen? But unfortunately, in an outraged culture, people are looking for reasons and causes. It's the same reason why coffee cures cancer, coffee causes cancer every other week, particularly because people aren't very knowledgeable of how studies are performed, and so they take that abstract and they run with it, and they don't look at the quality of the study. They don't look to see if it's an epidemiological study, if it is a peer review, if it's not a peer review, if it's a systematic analysis, or what the quality of that evidence is. And so what you'll see is these people that make a big deal out of something that really isn't, and a lot of that has to do with timeline. And this is an inherent bias that you'll see. So the thing about these strokes that go in is the population is the exact same, at least in this Medicare study, as the people that went to the family doctor, although one didn't touch them at all. So could it be that the person was going in with those symptoms already? Well, that would be a good one. Neck pain, headaches, those are actually signs of strokes in progress, right? The other is that the neurologists because they have an intrinsic bias already, or the neurosurgeons, typically what they do is they ask them if they've seen a chiropractor. They don't ask them if they were in yoga or if they were on a roller coaster, if they sneezed. And if they'd seen a chiropractor anywhere within the last 30 days, they attribute causation to that. And that's not really what the data bears out. So when I'm saying that, I'm saying that numerically speaking, I mean, in non-cardiac surgeries, you carry roughly a 1 in 33 to 1 in 35 chance of a stroke or myocardial infarction within the first 30 days. 1 in 12-ish chance of an infection. So the only argument you can make with that is a risk-benefit analysis. If you said that there was no benefit whatsoever, then that risk-benefit would be infinite. So you would say don't do it because there's a 1 in 3 million chance. It's not really what the data suggests.
What are we talking about?
Well, we went from neck cracking to something
I know.
crazy.
They're singling them out. just
We got a
because-
question on
I
that.
lost you, man. Wait, so we were talking about...
About relative risks of stroke, for example, associated with an intervention.
Got it.
So cervical manipulation. And again, you would never do that unless there was an indication. So you shouldn't crack your neck unless there's actually a medical reason to do so, right?
So and that brings up a point because you're YouTube famous now
Sure.
for cracking necks.
Amongst other things.
And literally, I think it was yesterday, 2 days ago, there was a story. I can't remember if it's Facebook or
It's an
Twitter
EMT.
where some girl gave herself. She used to crack her neck, I guess.
Right.
And she paralyzed herself, I
Right.
guess, because it was.
Wait, seriously?
Yeah.
Yeah.
That's
So you heard
crazy.
about it, yeah.
Yeah, of course. And so, that's when I have to pull up all the data because you can't make these sort of ad hoc and ad hominem arguments without the data to support it. So, 23-year-old EMT in the UK allegedly twisted or stretched her neck. It cracked, and then 15 minutes later, she began having stroke symptoms. So again, 15 minutes later, I mean, that is a temporal. It's close enough to where you can assume possible causation for sure. But what we're finding is there is a group of people that we think genetically, people with elevated homocysteine levels in particular, Marfan syndrome, people with EDS. There are genetic time bombs out there, and they're usually young people because they stroke out before they get old enough to have anything else happen to them. And so whatever that is, whether it's being in jiu-jitsu or sneezing or cracking their neck or stretching or yoga, there is a patient population that has these vertebral artery dissections. And again, what we think is that there's an inside part of your artery called the tunica intima, and if that is torn partly, what happens is your body forms a clot to try to block that off. What can happen is if you move your head even more, or if your blood pressure goes up or whatever else, that clot can break free. That's sort of why people stroke out on the toilet, right? Like there's a clot and they increase their intra-abdominal pressure and they increase their blood pressure, which is why blood pressure is a risk factor for stroke and heart attack.
What the hell are they doing on that toilet? Wow, okay.
That's how Elvis died.
The people, I mean, it's a very common thing, by the way.
We got a question. What is it, Nick?
Yeah, so the question is from Daria. She says the MMA technique for losing weight in the bath, is it just for short term, or if I keep doing that, will I get to the weight that I want?
Oh, no. That's a short term. And it's a very unhealthy short term too,
It's
by the
just
way.
dehydration.
What is
right?
it?
It's literal dehydration. So what happens is these fighters get close to weight. They get within 10, 12 pounds possibly. And so what they do is they get in a really hot bathtub and they heat themselves up so much that they sweat out all these pounds of water. And then what you'll see is that there's these wives' tales too about adding Epsom salt and adding alcohol, which is the really bad one. They add rubbing alcohol to it.
Oh, wow, I never heard that one.
Yeah, the idea would be, at least theoretically, that it would change the evaporation point potentially, but it doesn't. And all that it does is the alcohol evaporates. And then
So
you're
you
breathing
guys
out
using
fumes.
alcohol? Cut it out. It's not doing anything.
So Henan Barrow actually had that happen at a fight. He was breathing in the fumes and he fainted and hit
Oh,
his
Jesus.
head. And by the way, you're likely to faint anyway, right? The vasodilation
And how can you fight if you're dehydrated
Well,
and weak?
And this is sort of the issue. So they banned IVs several years ago. So what used to happen is they used to do that. So they get in the bathtub, they heat it up, they sweat it out, they put towels on, they mummify themselves, and they sit there and sweat out more of it. They dry off, go back in, or they do it in the sauna. And I've actually done this with John Jones before. I've done it with several fighters. And I guess I'm dehydrated because I only lost 4 pounds and he lost 12. So I don't drink liquid, so I guess I don't sweat the same amount. But anyway, what they do is they heat up their body. And so, there's massive amount of stress on your kidneys. You're completely dehydrated. And even the hematocrit, like the level of your blood is going to thicken as well, which, by the way, theoretically could put you at more risk for a stroke or a heart attack. Not to mention all the electrolyte deficiencies that you're creating, cardiac arrest. I mean, it's a very, very, very unhealthy thing. You're not losing fat. You're literally losing water. You're dehydrating your brain and potentially risking getting knocked out. So they used to be able to IV, which would kind of bring them back to life. Well, they banned those because they felt like those were masking
cheating.
agents.
Yeah.
Yeah.
So now they're having to try to chug water but now you have all these different hormones in your body, right? You have something called ADH, or antidiuretic hormone, all these things. So as you dehydrate yourself, your body releases this hormone to try to hold on to water because you're literally dying. So then what happens is once you've dehydrated yourself and you start pumping water back onto yourself, your body goes, let me hold on to as much as I can. So we wonder, hypothetically, maybe some of this dysfunction, at least cerebrally the next day, is it overhydration? Because you can certainly overhydrate too. In fact, people die from that at a alarmingly high rate as far as runners and people like that, because they don't replace the sweat that they lost with electrolytes. They just chug and chug and chug water, and they get something called hyponatremia.
Hyponatremia.
As your guest gynecologist, let me just confirm that that's a really bad idea. It's not healthy.
Which one?
Just the whole
cutting the weight
process
down.
of the acute trying to lose weight.
And that's, believe me, in the MMA world, that is every week, every day you
Gosh,
see
it's
that.
not worth your brain.
Yeah.
No.
And
So to answer a question, no, absolutely not. You will not lose weight. The only way you're losing is water. Don't do it. If your goal is to lose fat, what you need to do is be on a calorie deficit diet and exercise.
There you go. And then
So
we
I
got
hope
another question.
hope that answers your question.
Well,
You
for
know,
athletes,
thank
they
you.
have a rehydration protocol, right? I mean, usually, hopefully, that's what you're saying about
So
IV.
the question is who's putting these things together?
Yeah.
There are a couple scientists in the community, Dr. Andy Galpin. There's another one down at ATT. They're PhD guys. They are studying this, but by and large, this is done by fighters who have done it before. So there's a lot of anecdote going into this, and we don't really know what the long-term ramifications of. If you guys have seen the videos of Cyborg cutting weight or any of these other people, I mean, they're pretty horrifying. And then there have been many people, including Nico Montano, who's the UFC champion. She had to go to the hospital. They cut her weight cut, and they ended up stripping her belt as a result of it. She lost her belt because she couldn't.
She hasn't fought since.
Make that weight.
They're really messing with
and
her.
so then it costs you, $60,000. In that culture, and it's really from the wrestling culture, is really where it comes from. The idea is you want to be bigger than your opponent in the octagon. So if you can cut that water out and put it back in, and you're 5 to 10 pounds bigger than your opponent, the idea is that you have an advantage. Well, I mean, offset that with the amount of physical trauma your body's gone through, mental, emotional trauma as well.
Absolutely.
I'm not sure that that's the case.
So maybe
We had that happen with my kids' grappling tournament. Another team was weight
At what
cutting
age?
6 to 9 year olds.
Oh
What?
my God.
that's insane.
My 6-year-old was like a foot shorter and probably 10 pounds disadvantage, but he hung in. He didn't win, but it was like, wow, my goodness.
So
Wow, that's a setup too for body dysmorphic.
Oh, for
Yeah.
sure.
Syndrome.
And psychological problems in the future, and Adonis syndrome, and all these other issues. Let's spin this a little bit. So Doc's a very evidence-based doc. She's very rational. I want to hear her thoughts on the internet and what's happening with the anti-vaxxer movement, essential oils, and how that is becoming popular, and then also your thoughts on interprofessional working between, say, chiropractors, physicians, physical therapists, and how those things can work well.
One at a time. Jeez, anti-vaxxing, first of all. What's up with anti-vaxxing? That's big right now. What's your take on that?
Yeah, I
Should
think
we do it or not?
it's big. I think that what a public health crisis. Honestly,
You got kids?
I do have a 14-year-old
Okay, so
vaccinated.
there you go.
Yeah, we eradicated
vaccinated.
measles in this country through vaccination, and now we're dealing with hundreds and hundreds of cases, and I think it's really
Scary.
it is scary. It's scary.
That's how that zombie apocalypse stuff starts. I believe it.
And I think that the etiology or the place that this arises is this fear-based inaccuracies spread through the internet, and the science that we know, right, is the same science that brings you the intensive care unit that saves an 8 or 9-year-old little boy with the measles, spends 8 days in the ICU, and unfortunately, you get the measles once, your body, it doesn't form an immunity.
Yeah.
You need to be vaccinated. At the end of the ICU stay, after these physicians and nurses and everyone has given everything to take care of this child and saved his life, the parents at the end don't want to vaccinate him. And I just don't understand I want to call it ignorance about the science.
No,
Why
let's
would
call
they
it
allow the
ignorant.
science of the ICU to save him and not rely on the science of what we know about the disease process to be real. And so I do feel strongly about it.
Me too.
I don't understand really the putting your own child at risk, much less other people.
Yeah,
at risk.
that's the thing. Your 14-year-old, if he or she didn't get vaccinated, goes to school. Now they get the measles. There's other kids in there. I mean, yeah.
Well, the issue is, what if my son is someone who actually cannot get the vaccine because of a medical issue, an immune issue, or a reaction to the actual vaccine? And
Lost
so
our herd
he's
immunity.
right, and he's fine as long as everybody's vaccinated, which is what we used to have. And so now he goes to school, and there are anti-vaxxers there, and they give him the measles. And that's the sadness of it, right? It's
and
someone
it can be
who
fatal.
Oh, absolutely fatal.
Yeah.
Wow.
Or you can get polio and lose your leg and die from that. And
Get your dang shots, people.
Yeah. So, and I'm going to let her talk a little bit about the etiology and why the diagnosis of autism and that spectrum is up. But here's sort of why they believe what they believe, right? So it's shifted over the years, by the way. Every epidemiological study that's been done, every meta-analysis has never shown a link between the two. And vaccines are one of the most evidence-based medicines that it's like the gold standard of all evidence-based medicine. It's like we're just going to ignore the fact that your immune system has, B cells and T cells and it learns, and that's insane. So it used to be that there was this fear about preservatives, particularly mercury. And so even though there was never any evidence that was a causative effect here, they removed those from those MMR shots. So the only vaccine that still has the thimerosal in it is a seasonal flu shot, which generally speaking, is something you're going to get a little bit later in life. So now what the conversation has now turned to, it's you don't want to expose your child to that many viruses in that short of a period of time. It'll overwhelm their immune system, and that will somehow give them autism. And my argument to that is, how many microbes do you think your child is running across as it crawls across the floor and puts things in its mouth and touches things? Exponentially more. And by the way, that's a good thing. That's good for your child's immune system. You don't want to end up like the bubble boy baby syndrome where their immune system isn't capable of handling anything. And Lee would probably be able to speak to this too. There are theories that lack of exposure early on leads to a whole host of psychological disorders later on, and it might lead to immune problems as well. Even potentially hyperimmunity later on, because your body never learned to deal with anything. So that's certainly not the case. There's no reason why exposure to particularly innocuous viruses, because those aren't the live versions that you're getting in those shots. They're basically designed to create a marker that your immune system can pick up on, and when they see that marker on a live virus, they know it and they go and kill it. So that theory is also bunk. So I'll let her sort of talk about like the diagnosis of autism and why that's increased, and what are some of the factors that she thinks might be related to that.
Yeah.
God, that's
a
that
big
is
one.
so outside of gynecology.
Well, you're still a physician, and you're still talk to many physicians.
Autism.
So, autism.
That speak on that.
Well, I'm going to speak up about, there was one guy who came out and said that there was a link between, vaccinations and autism. That he later even said
there was
yes,
he recanted.
he recounted.
Study.
He said, "I falsified it. It's bunk."
Oh, jeez. But it's
and
staying
yet still,
out there.
it is out there. So it is unfortunate. And
It's like those people that say we didn't land on the moon. See, it spreads and.
Well, and to Bo's point, that vaccinations are one of the most well-studied components of medicine that we have, and we've got outcome-based data. Millions of lives, right? Millions of lives as outcome-based data. So that and the link to autism has been disproved over and over and over, and so I can't account for why the ignorance that people choose to live their lives with. And I think that I don't think we actually know the etiology of autism. What we do know are about insulin disruptors. Endocrine disruptors. So these are substances in our life now because of this modern society, and we're exposed to chemicals and the breakdown byproducts of chemicals. They are literally disrupting our endocrine systems. To me, that is far more scary than some hypothetical association, when we can point to the plastics, the petroleums, the fragrances in our lives and know that there is real data that says, hey, these are really bad for developing children, developing brains, pregnant mothers. We're changing our entire
physiological makeup.
Thank you. Yeah, related to the things in our environment, and to me, it's a bigger issue. That's a real issue that we can actually combat.
Right. Looking at BPA and looking at our fertility rates and things like that are changing. And
people think we're getting stronger, but we're actually getting weaker, I think.
Well, here's the other scary thing. We didn't talk about antibiotics, but we are soon to be out of antibiotics.
Options.
We're going to be out of options. And so what, 80 years now,
really?
Right, that we've had antibiotics. The bugs are changing far faster because we're not good stewards of the use of antibiotics. And so we've created these resistant organisms, and now we're using double and triple and quadruple antibiotics to treat some infections, and we're going to be out of options. We're going to be back to a time when people died of simple infections.
Yeah.
That's scary.
And
it is scary.
Like MRSA, for example, methicillin-resistant Staph aureus. So what happens is their lifespans are so short, right? When we interject something, we create a bottleneck genetically. All it takes is one mutation, whether it's from UV radiation or whatever else, and that mutation allows it to survive this, and that propagates a population that grows and grows and grows. So like she said, we're not being good stewards of that. People aren't finishing the prescriptions. They're not killing everything off. There's a lot of problems in the way that they're being used.
What do you mean they're not finishing off their prescriptions? So like if you're given a prescription, antibiotics, you should take it till it's empty, it's done. Don't stop mid-range or mid-bottle, whatever. Is that what you're saying, or what do you mean by that?
Yeah, absolutely. Take the full prescription.
And
there's a reason you gave 15 pills. You want them to take all 15 pills. Don't
take
just because you think you feel better.
And don't give them to other people that they're not prescribed to.
Right, who take then one or two, and then they think they feel better, and then it's just a bad cycle.
Yeah.
You were talking about essential oils too. Sorry. What are your thoughts on those?
I'd like
because
everybody's.
I don't even know.
It's a trend.
What
People,
component?
it's a trend.
What's
so
essential
people
oils?
are trying to treat medical conditions with essential oils.
Yeah.
Like what medical
like
conditions?
CBD stuff or what?
No.
Like the lavender. One of my friends' mom said, she passed away from cancer, but she was using essential oils for cancer to treat cancer, maybe along with the chemo or instead of the chemo. So
this is happening a lot, by the way,
and it's another trend. I think.
I think it's tragic. We're a sophisticated scientific culture that people are willing to accept the science when it fits them, right?
Yep.
And then call the science bunk because they want to believe something else. I think it's tragic. That someone, and people do, right? That they choose to live and die the way that they do. I don't see any evidence. There's no evidence about essential oils for that particular
or
use,
really
right?
any medical conditions.
It's just really a huge market to
Not
make money.
allergies, not pain.
Yeah,
there's literally, and again, I'm saying there's no evidence. I'm not saying there's evidence against that. I mean, that's sort of a tricky thing too. It's a philosophical question, right? And I think a lot of people that are experts in the community, and you hear this in discussions all the time, like we get away from our a priori statement. So when you're discussing one thing, you don't use analogies, you don't use straw mans, you don't use any of those kind of things. And I think when we say we haven't disproven something, that's not the way you study things. In court, you don't prove somebody innocent; they're either guilty or not guilty. So you can't prove that things don't work. You show evidence that you have no evidence that it does work. It's sort of like Russell's teapot, if you guys are familiar with that, right? So there's a teapot, between Jupiter and Neptune. Prove that it doesn't exist, but you can't. The onus of the burden of proof is on the person who says so. So if you say lavender can cure something, you darn well better have some evidence for that. And it's not acceptable to say nobody proved that it didn't do that, right? And that's sort of the argument they use with vaccines. They'll say that they haven't proven that it didn't do that, and that's not the way this works. You have to you back up your claim with evidence that your claim is true. Okay, and if we study it and that doesn't prove to be the case, then you have to accept the literature as is. And I'm not saying that there isn't an outlier. Everything happens in absolute numbers. Is there probably a tiny fractional portion of society that somehow there's an epigenetic activation of some sort of gene in combination with 9 other genes that might lead to autism. I think it's possible, but by and large, the vast majority of people will not have that sort of thing happen. And I think that, as we've heard psychiatrists discuss this and everything else, I think people have a hard time accepting that it might be, I don't know, their genetics or something like that. They look for something that happened again in that timeline, the post hoc ergo propter hoc logical fallacy. So around that time when those symptoms start to show up, what happened around that time somewhere in there? Well, they had vaccines. They're not really in school yet. There's nothing else they can sort of blame it on. And they don't want to look in the mirror and say, was it my genetics? Was it nutrition? Was it something else? So there has to be a bad guy. And it's a tragic thing, and autism is a serious illness, and those kids, they need to be loved. And I think that there's other things that go along too. I think that because of the internet, and this is sort of, essential oils, anti-vax, or flat earth, YouTube is this portal to appeal to people who don't have a fundamental understanding about these things. And it sounds convincing because these people don't have basic logic or philosophical understanding or science understanding. So they're like, well, I'm going to drop this pen right now, and do you know why it falls down? Well, it's not because of gravity. It's because this is more dense than air. What do you mean? that doesn't make any sense. They still would have to have gravity. Have you not seen the experiments where they drop a feather in a bowling ball with no air and they fall at the same rate?
So much misinformation out there.
So much for Newton.
Right, and so there's this misinformation that can propagate, and we end up with all kinds of nonsense. You end up with the birther stuff with Obama's birth certificate. You end up with, and I think the Russian collusion falls into that category too. You have all of these reports that came out and said there wasn't collusion, but people continue to believe otherwise. Like, we have this fundamental belief system where we won't believe what we see in the evidence. So when Obama shows his birth certificate, I don't know what more you needed. The fact that we got there in the first place is sort of a different discussion. And the same thing with these vaccine studies, and the same thing with these other studies. Like, unless you have some sort of evidence, and again, I'm not saying evidence is the end-all be-all of everything, but it forms the foundation of your philosophical discussion. The analogy I like to use for my students is if you're talking about medicine, for example, you're on the freeway, the guardrails are the evidence. You don't want to go off the road. So unless you have some sort of evidence that tells you you're going that direction, you're going to go off the road and drive into a ditch. Okay? Then your physician helps you choose which lane to drive in. You don't want to drive too fast. You don't want to drive too slow. They're going to help guide you to the right intervention. And then the patient sort of decides what exit you get off on. So you need all three of those things to make sure you get to the right destination. And I don't think that we're getting enough of that.
I like that.
Not only in healthcare, but, in the way that we philosophically approach everything in life, from philosophy to, the geometrical shape of the earth or whatever else. And we have an academic crisis, unfortunately, which is insane when you think about the amount of information that we have access to. You have a supercomputer in your pocket at all times, and you could fact check things.
Let's shift gears. Marijuana. What's your thinking on that?
Oh, man.
You ever prescribed it? Can you prescribe it? I guess being a medical doctor.
I could.
You could?
With my license, for sure. But, I'm not taking care of patients with
cancer,
chronic issues that need it. And I'll give you just a personal experience is that having gone through chemo and radiation and had nausea, that was so awful.
And did you already tell them you're a cancer survivor?
No.
Oh, yeah, I'm a cancer survivor.
Wow,
yeah.
good.
Yeah,
Wow, that's good.
It is good.
Yeah.
It's good.
It's great.
But the nausea was so terrible. Nothing would work.
How long ago? Let's.
3 years ago, actually.
Okay. So the marijuana thing was out there.
Well, and I actually got treated in California, so it was available, right? Interesting, as a professional, I cannot, in New Mexico, have a medical marijuana card and continue to be
a licensed physician.
So I've got to choose, right?
Oh, wow.
So she can't consume.
Interesting.
That's right. So it's not that I could have chosen to continue
with chiropractic.
To work through my chemo and radiation and also use medical marijuana.
So
I can't do it at the same time.
So did you try it? I mean, was it something?
I tried everything because it was terrible. I tried every edible possible, and oils and tinctures and oh my gosh, everything.
All the CBD,
Topicals,
the THC,
I tried it. I tried CBD. I tried THC. I tried it with both.
And what worked?
Nothing.
Really? Wow.
Nothing. Baked potatoes. That's all I could eat.
Wow.
Holy crap! That's
so
horrible.
From that perspective, I would have these conversations with women who were there for at the center getting treated for other cancers, and would swear by it. It was so life-changing. They were on different chemotherapy regimens, and the nausea was terrible for them as well, and they could have a few tokes or gummies or whatever they were using, and it changed everything for them.
Yeah, I was going to say, so what if a patient of yours says, Doc, I when I'm giving labor, I must use marijuana? What are you going to tell them? I mean, they're under your care. How does that work?
God, it's so it's so tricky because now I think number one, the access to a card is so easy. There are physicians, there are people with a degree of that are, I think, inappropriately giving out cards.
Yeah, there's doctors out there that specifically that's their purpose.
That's their deal. And,
so you're going to tell
that's
that
what they do.
patient, yeah, go find that doctor. That if they'll give you that card, then do what you got to do. Or what
It's just not me. I do think there's a place for it, and I think that there's a reason that the medical marijuana movement is what it is, and it's been abused, but it's also providing a great service for a lot of patients who really rely on it. It's not just for nausea; it's for, insomnia, other issues medically, and
It's a wide spectrum.
that's right. And these professional women
Pain,
in this same group, I actually didn't have a card in California. Someone had gotten it for me from a dispensary, and none of them would, even though they could have a card, would do it because they are lawyers and they're professional women, and it was the same thing for them, that they cannot in their professional lives also have a medical marijuana card. It was just like...
So in California, you can have a card and be a physician?
I actually don't know California laws,
Okay.
but just in this group that I was with, it was politically not okay
Okay. Yeah.
And
to be a professional. And so I don't know if that was...
But in New Mexico, flat out, no.
But in New Mexico, I know for sure that I
Yeah.
cannot have a medical
I mean, it's still
card.
a Schedule 1 federal, drug.
Yeah.
Even though states are
Yeah,
allowing
even though
it.
the states are getting easy, there's still that federal law that says no.
Yeah, and I think this is less from a medical perspective, but I certainly have seen anecdotal cases, and there's some literature. It's sort of mixed on the literature side, but certainly anecdotal cases of people that I know that have done well with it, and the risk benefit is pretty good, especially when you compare it to other things that we allow culturally, like alcohol and cigarettes and things. So,
That are legal.
Well, and CBD is actually very well studied now
Right.
and decreases seizures.
right,
And
yeah.
for certain types of seizure disorders. So I think...
and there's some interesting data on autoimmune for the gut and things like that too.
But it will be abused, as things always are, and people take advantage of the system, which means that why not just legalize it and teach our children responsible drug use, just like we teach them about alcohol.
Everything.
Yeah,
I
sex
actually think-
education.
Alcohol's horrible.
Right?
I mean, everyone drinks. 21 and older, but it's horrible.
Well, and I personally
But we don't
believe
teach
in-
responsible drinking.
Right, and so as soon as they get it, they don't know what to do with it.
They don't know
and
what to
go out
do,
of
they
control
drink too
and they
much.
binge.
They drink and
Education.
drive.
Yeah, and then there's real world consequences. So
And there are
ahead.
consequences with marijuana for young developing brains. So I don't
Right.
think that just like we are not giving alcohol to children and we wait till
5-year-olds,
they're
right?
21 years old, and even then it's probably a little too soon with the whole myelination of the frontal lobe for young adults.
26ish.
Yeah, we should teach responsible drug use and wait until the brain is done developing.
Well, and then when it's done developing, I'm not too sure, but the neuroplasticity, it takes years or a year to grow back just even a little bit, right? If you smoke too much or you do too many drugs,
I'm not sure.
no?
Yeah, I don't know about that.
I
No.
don't know.
But
I read that somewhere.
Might be true. I think looking at the legislation that they had in place too, like when it was up this time, from an economic and societal standpoint, I have patients that run dispensaries, and essentially the legislation was going to put all of the marijuana in charge of the state, and so they were going to raise the price, and they were going to basically hold it at a certain price point, and theoretically, and again, this is why things are so nuanced and complex, I thought that sounded like a good idea, sort of like sin taxes. I'm a big fan of value-added taxes and VAT taxes on things that people don't necessarily need that they want, entertainment, and I feel like property tax and income tax are sort of unethical in a way. And I understand we need some level of income tax, but I mean, to me, a progressive tax rate is in a way bigoted. I mean, you're saying that certain people pay a different percentage than other people. So I think choosing to charge things like alcohol, cigarettes, lotto tickets, expensive cars, watches, bags, things like that, pretty hefty VAT taxes, would be a nice way instead of charging, gross receipts on medical and groceries and things like that. So what this guy explained to me is he said, do you think all these dispensaries that are out right now and growers are just going to go away? You're going to create a black market just like there was before. So if homie down the block is like, oh, it's going to be $15 here, whatever for a dime bag, and I don't know the lingo for marijuana. I'm obviously not a marijuana user, but he was like, hey, listen, man, I'll go down the block to my other guy and get it there. And so you create this underground, even though it's legal technically, you didn't make it actually legal because you said it's legal as long as it goes through these means. So just like it is now, you create an underground network which creates gang activity. And what do they really have to do when drugs are illegal? And it's like prohibition with alcohol. I mean, you said, okay, we're going to get rid of it. But at some point, things are so ubiquitous that you cannot regulate them anymore. Marijuana, in my opinion, has gotten to that point. It's like guns. There's no way you could possibly do that. They're too ubiquitous. You will create the biggest black market gang, culture ever if you tried to make guns illegal. They're too ubiquitous. If you had a population that only had a few of them, you could do it. But just like alcohol, cigarettes, I mean, they couldn't ban cigarettes either, right? Like, theoretically, from a public health perspective, you should, right? Like,
yeah, we know what happens if they try to ban alcohol or.
Well, they raised.
Like
the price of one pack is, I don't know. You go to
like,
Circle K,
it's like $6. What is it?
Right.
$7?
That would make me stop
$7,
smoking
yeah.
right there.
Yeah.
But the difference is that a cigarette is a much more processed product, and it's very easy to grow marijuana and smoke it and sell it. It's not. I don't know. I've never made cigarettes, I suppose, but it seems like it would be a much more odious process to package Marlboro oils and sell them to people and put filters on them. So I think that's sort of part of the reason why you don't see an underground cigarette culture and a gang culture with cigarettes.
Well, I think that's part of the reason to legalize
Agreed.
marijuana in some of these states. They're saying, hey, let's at least get some benefit, and we're going to tax it, and we're going to, put some money back in the state.
And we're not going to put people in cages and still boxes for,
That's right.
putting substances on their body. Like,
Cages.
that doesn't heal anybody.
Yeah.
Jail.
Jail. I mean, all the
cages. Yeah, I know. I'm thinking MMA cages.
Well, no, it's like I saw the meme the other day, and it was an interesting meme that said, "Hey, we're the government. We want you to guess how much you have to pay in taxes." And they're like, "Just pick any number." And they're like, "No, we know exactly how much." And they're like, "Okay, but you make me tell." They're like, "Yeah, go ahead and guess." And they're like, "What if I'm wrong?" Well, then we come and get you and put you in jail.
Throw you in
Like,
jail. Exactly. Yeah. They got.
No, we know exactly how much you're supposed to pay. And I just find that interesting. And I think that goes back to sort of what we were talking about, and it's an ideology. We've lost so much trust in the system. When you look at all the lies that the government has told us over the years, whether it's the Tuskegee syphilis experiment, whether it's the Tonkin Gulf incident, the entire war in Vietnam, whether it's the Iraq war and the weapons of mass destruction, whether it's the Russian collusion, whatever that is, we've lost distrust in authority. The big pharma, and that loss of authority in our community, the medicine is the authority. And so if you don't trust your government, if you don't trust the other authorities in your life, people have lost a lot of trust in religion. When you look at what's happened with the Catholic Church and all those other things, basically the instinct now is anything that's an authority is wrong and lying to you. And I think that has led people astray in a lot of ways. And my guess is that's probably a big part of what's going on with the vaccines and the essential oil movements and stuff like
The
that.
misinformation.
Too. And this is coming from somebody who, I'm a licensed naturopath now, so I'm under the medical board. But I have been a licensed chiropractor, and chiropractors tend to be sort of antithetical to medicine, and a lot of that has to do with the history of the professions and the fact that the AMA tried to eliminate that profession. And so the response to that is not to be neutral. The response is to attack the opponent. And so that means that everything in there must be bad. They must be trying to poison you, which is not the case. Are there errors? Of course there are. But, by and large, the medical community does as good a job as any as following evidence-based guidelines, better than the chiropractic community, actually.
What doctor? What brought you to Jackson Week today? Did you hang out with Dr. Bo or?
Yeah, any chance I get to hang out with Dr. Bo, I'm there.
Sweet.
Yeah.
Have you been here before?
Yeah, so I actually saw Bo professionally about almost 5 years ago.
Okay.
And I tell everyone, because I actually send a lot of people, not only patients, but anybody in my life that's got anything, to Bo. And my experience with him has been that he is the best diagnostician I've ever seen, hands down, including any MD or DO that I've been involved with.
Awesome.
And I've never met someone who's so analytical and smart about the neuromuscular and skeletal system. And
Shout out Dr. Bo, man.
Shout out Dr.
Look
Bo.
at that head, how big
Really?
it got.
Yeah, I'm a biscuit. Stop trying to butter me up here.
Yeah. No,
I'll
and
pay you afterwards.
and so when I tell people that, they're like, how do I get
No,
in
he's
to,
a
how do I
badass,
get in to
dude.
see him? And I
Yeah.
said, well,
We love
it's a
him.
little bit of a wait, but it's well worth it. And
Has he cracked your neck?
no, he doesn't. No,
He hasn't done that?
no. It's more of every now and then I kind of get all compressed,
We do a
and so the
traction as well,
traction.
So you've done the traction. You've
Oh, it
done
just-
stuff with him, yeah.
Yeah,
It-
you've done that to me before. That was amazing.
Yeah.
Oh, he makes me cry. I didn't say he didn't make me cry.
Oh, he's made us all cry, believe me. He's
But,
made
you
it.
know,
Yeah.
we
a
work
good
through
pain.
binary logic, okay? We have an intervention, we have our theory, we work through it. If it doesn't work, then we change our approach and until it works, and then we try to teach her to take care of herself. And I think Lee came in first, right?
Lee saw you first, yeah?
Yeah, and how did she end up coming in? Do you remember how that?
Yeah, it was someone from our tennis club.
Oh, interesting.
Yeah,
That's-
word of mouth.
That's your wife.
Yes,
Okay.
my wife,
So
Lee, yeah.
So
And
now
then
you're
she
both
forced you
patients.
to come in, I think, right? She was like, she's got so much stress and tension, she needs this.
Yeah, I don't even remember, but
You were
it
doing
was
a ton
love
of
it. It
surgery
was
at the
love
time.
at first sight.
She's like, oh, this is good.
oh, I was doing so much surgery that I walk around like this. It hurts
Yeah,
so
that
bad.
repetitive motion.
So now you can be one of our MMA doctors in the cage
Yeah.
after.
In the cage, yeah. I
Have you
carry
seen
around a
those
little
doctors?
a little suture kit, and a
Have you
little
seen?
glue.
Have you done it before? Have you been to a fight?
I have not been to a fight.
Oh, we got to get you. We got to get you to one of our fights coming up.
Yeah.
And
Absolutely.
We got one coming up in May.
Yeah, there's probably not much use for a gynecologist in the ring, though.
No. That's all right.
Other than suturing.
That's all right. In between rounds, when someone gets their eye cut or something, there's doctors that
Yeah.
decide
Yeah,
if they
and we
can
need
go.
people to run a good physical, too. You know?
that I could do.
Yeah.
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 Yeah, so it was pretty cool. And then, you know, we've been lucky enough that they trust us with their son, you know, and you know, it's been a really great working relationship. And she's actually taking care of some of my staff, too, that have had to have some really major operative stuff done. And she's done an amazing job. I can't say enough good things about Dr.
There's a
Stewart.
lot of
Yeah.
years of education on that side of the room. I can't say that about this side, but
I was just listening. That was more than I could have got from a textbook.
Yeah,
awesome.
so, you know, we're really grateful. And frankly, you know, New Mexico, she's a native New Mexican, obviously. So
awesome.
we don't get to keep a lot of great physicians, unfortunately, you know, based on the economy and the way things work here. You know, most of the good physicians leave. So, you know,
Thank you for staying.
New Mexico, you know,
Thank
be
you.
grateful that you have a great surgeon like this.
Both of you guys.
Are you from
around.
here,
Yeah.
Bo?
Yeah, I'm from here,
Yeah.
but I may not be here forever. So,
He's a Lobo.
He's looking
I'm-
elsewhere.
Play- for
yeah,
the
I may
Lobos.
bail on you guys. Sorry, guys.
No, you ain't bailing on us. Screw you.
No, look at his
Yeah,
face.
where
He's
you
like,
going?
You ain't,
I know.
you ain't leaving, man. You already did the Dallas thing. I mean, come on, you're
Number
staying.
58. That's how many times I've been in your office.
Really?
I know his jersey number. Yeah.
58.
Jersey? What? Football?
Football
Yeah,
jersey.
Yeah, he played for the
Nice.
Lobos.
from
Yeah.
Oh,
Mexico.
cool.
Yeah, and you've had a whole host of different things over the years. You know, just regular neck stuff, regular back stuff.
Oh, and
Um,
then I had this pelvic fracture after the radiation. I had
Oh, jeez. Pelvic fracture.
someone push on me and basically break my pelvis.
Someone.
And
They were
so
trying to-
no, someone
Wasn't
not
me.
Bo. No, not Bo. I came to Bo after. Said, "Oh my God, I can't even walk."
Wow.
And then I got in a car accident. I was beat up from that, and needed Bo. And then it's just the daily stuff. So I'm on a really great regimen.
Yeah.
It is like every
She
day
needs me
of
less
homework.
and less and less, which is awesome.
Yeah,
Where'd you go to high school?
Del Norte.
Oh, okay.
Yeah.
So
And then I went to UNM for undergrad and medical school.
Yeah.
And I went to Chicago for residency and fellowship training. And Chicago's a great city. And New Mexico,
the Windy City.
it was home. I think the way, yeah, Money City. But, you know, Mexico's home, and there are a lot of things we don't have, a lot of things we do. And
Yeah, Mexican food. That's why you
Say
came
New
back.
Mexican food.
The New Mexican food. That's
It
why you
is-
came
yeah.
back. The green chili, man. You
And
can't.
the mountains and the outdoors and
Yeah,
family.
Weather's great.
This is where family was, right?
Yeah.
Perfect. Well, I'm glad. I'm so glad you're here. I'm glad to meet you. It's awesome. This is a great show.
Yeah.
I'm glad Dr. Bo talked you into coming on.
Yeah, yeah. And what do you think? You got so if you could take 5 health pointers for people out there, just general questions that you get on a day-to-day basis, or that your friends ask you about that you could get out to the community. What are 5 or 3, whatever,
Q&A time.
common things that you are asked about that are just common public health questions or women's health questions that are important because, you know, the people that are watching, either they are women or they have women in their lives that maybe misunderstand birth control or whatever. Like, you know, what are some common things?
I would say, first of all, that women have choices. And as women, we tend to form relationships with our physicians, and so that tends to be the obstetrician. We have our children with them, and then we are with them for many years, and then it comes time where we need something that's gynecologic or even gynecologic surgery. And instead of seeking out the best gynecologist or gynecologic surgeon, we allow the person to do our surgery who's been there for our children and all of our lives, and we're very attached. But that person may not be the best at doing the surgery that she needs. So be open to seeking out the best for what you need, knowing that that relationship will still be there, right? Your physician relationship. You're not going to offend your physician because you're seeking out someone who's just really good at what they do. Because there's too much now. There's too much. This is gone are the days of the family physician that is also the surgeon and delivers babies. It's gone. And there's too much, and the fields are so narrow now, what we're really good at. So give yourself permission to actually seek out the best if you need surgery or something that your physician isn't very good at. I would say the human papilloma virus, there is a vaccine. Speaking of vaccines, and it is decreasing the incidence of cervical cancer.
That's the HP, what
HPV, the human papilloma virus,
yeah.
HPV. It now has an expanded indication up to the age of 45.
Wow.
And we start vaccines for girls and boys. And when I explained to my son, hey, you could get this vaccine, and it would actually prevent you from transmitting the virus to someone that you loved. This is the virus that mommy had, right? And I got cancer. So explaining it to a little boy that, hey, you could take care of the person that you love, that you're going to be in the relationship with, he was all for it, and it made a lot of sense to him. So really consider vaccinating, and if up until the age of 45 decreases the risk of cervical cancer, it's really important. Birth control.
Mm-hmm.
Birth control for women, it should be really empowering. There are so many decisions, so many options that women have to make a decision for birth control, and that in choosing birth control, you're really just taking your life and you're saying, this is what I want, this is what's important to me, and making the choice that's right for you, and finding out all of your choices, because there are a lot, and you shouldn't have to settle for either not having. I mean, if you've got access, there are lots of ways to get access to birth control, and just know that there are a lot of decisions, a lot of options that you have to make a decision that's right for you. But that should be a very empowering decision. It's your life, and
Take it in your hands.
Yep. And so I'll just leave you with this, which is for us all. We get this one life, and we have this moment now, and we learn to live it and make the best decisions we can for ourselves and the people around us. And so live this one moment.
I got to hear a cool story
Yeah.
though. Come on, have you done a house deliveries, or been driving down the side of the road and delivered a baby on the side of the road, or anything cool like that? I mean,
Well, there's the occasional, on
as
the
an option.
airplane, and is there a doctor on the plane?
so that's happened
Yeah,
to
those
you.
are.
And actually,
yeah.
I'm not a real doctor, so
Yeah, Bo never gets up.
find an MD.
Bo never gets up.
Crack me up,
Yeah,
though.
and then the ones where you walk toward the back, and the airline attendant is there, and a man walks up too, and she wants to see your credentials as a doctor.
Oh man.
Yeah,
Really?
yeah. She's like, she wants to see my credentials. Are you a doctor? I'm a doctor.
Sexism in
Can I see
medicine?
sexism in airline attendants? By
Oh,
the way.
okay.
Wow.
Yeah. I don't know. Funny story. I don't know.
It's just very serious. Just surgery, just serious stuff.
Saved a lot of people's lives.
Yeah,
You
I
know.
bet.
I haven't saved people's lives at all. I've
Oh, come on.
No, I've improved their overall quality of life.
Yeah.
But I'm not in the the arena of really saving lives.
You're not in the
Well-
ER doing all that crazy stuff.
No, those are hard jobs.
Oh, believe me. Yeah, that's fascinating stuff.
Yeah, we're losing ER docs too. We don't we're not taking care of our physicians in this country.
That's too bad. That's tough to hear. Everyone wants to be an attorney. We got too many attorneys and not enough doctors now.
Not enough doctors.
What about you, Bo? Same question.
What's that?
5 things.
I could only
things.
come up with 2.5.
Man.
Yeah.
So I gotta match that and beat it by half, right?
Is there?
Yeah, I mean, I like that. I think it's important when you're looking at clinicians to make sure that the things they're saying are rational. So, I defend chiropractic as a profession, in generally speaking, because I think there's a lot of misunderstanding about what chiropractic is. A lot of people think of it as an intervention, and they say chiropractic is a bunk science. Well, chiropractic doesn't proclaim to be a science; it's a profession, much in the same way optometry or podiatry or any of those other professions are. So it has a scope of practice within it. It varies from state to state. In New Mexico, for example, advanced practice chiros have DEA numbers, and they can prescribe, ibuprofen and cyclobenzaprine, and they can do sorts of injections. But they're trained to do that. So because chiropractic has fallen into a CAM or complementary alternative medicine umbrella, there are people who are woo-wee that find themselves into that. So on a per capita basis, there are certainly more quacks in chiropractic than there are in medicine. Are there quacks in medicine? Of course there are. I mean, there's a lot of, especially the online gurus, the only eat this diet or don't do this, I mean, anything in absolute, you should probably be very wary of that clinician. Because again, a good clinician is nuanced, and they understand that everything sort of has its place, and you're just trying to find the right person for the right place. So nothing works for everybody and vice versa. So anytime you hear a healthcare clinician make some sort of claim like that, that's the time to move towards the door. It's important that clinicians stay in their lane as well. When I see a patient with a case that I know that is outside of my scope, I don't proclaim that I think that it's, I'll tell you, I think there's something wrong here, and I think it's within this wheelhouse. I want you to see an endocrinologist or rheumatologist. I think you referred me a patient that was something similar to that. I evaluated him. I said, I don't think I can help you. I think you're better served being here, and we try to pass them on. So I have heard of chiropractors. They have a bottle in the front, and they ask people to put their prescription medications in it. That's horrifying to me. So when people ask me if they should be on this medication, I said, well, you tell me how you're feeling, and then you need to go back and discuss it with the prescriber. So as somebody who's a non-prescriber, it's not my place to be discussing whether somebody should or shouldn't be taking a medication. And I think it's important that professionals respect each other's boundaries in that sense as well. So if you have a clinician that isn't doing that, for example, chiropractors giving advice on vaccines who do not give vaccines, I think that's time to move towards the door as well. So I think it's important when you're listening to a healthcare clinician, if your spider sense is going on and something sounds like bullshit, that it could be bullshit.
Follow your gut.
Get a second opinion, get a third opinion. Trust in other healthcare professionals. Don't put all of your eggs in one basket either. Like she was saying, the age of the GP that did everything is sort of gone. So you need to have a network of healthcare professionals that can help you navigate the system and get you to the right professionals on other parts. That's one, right? Part two.
Four more.
I think it's important, like we were talking about, to take sort of a binary approach to yourself too. So it's very difficult to be objective with yourselves, and her and I could both attest to that, because sometimes when you are very prideful and you have a lot of medical education, you may let symptoms go on longer than they need to because you convince yourself that something else is going on. Yeah. I certainly know that's what happened with me and my UC diagnosis. I should have gotten in earlier, and that may be the case with you, that you notice some things, but you kind of busy. That's definitely me. So when you notice something, I'm not telling people to run to the doctor every 2 seconds, but if something lingers for a week or two, go get it checked out. The early intervention helps a lot in cancer diagnosis and all kinds of diagnoses. So you're better off getting a hold of it earlier than trying to rub essential oils on it, and then you get to the point where it's too late, and it's terminal.
We diagnose our cars more than ourselves.
Yeah, we can save a lot of lives by getting in early on and just getting things checked out. Now, we're not advocating for abuse of the medical system in that sense, because there certainly is overuse of MRIs and imaging and things like that. So I guess the third one would be and it's a philosophical approach, so I'm just saying binary. So do one thing at a time with an intervention. Don't try to do 4 things at a time. That way you know if it's helping you or it's not. If you do 4 things at once, you're not really sure what's helping you or what isn't. And then something that I talk about in our practice a lot, it's triangulation, and I talked about this last time we were on the show. So imaging is a tool. It is, an image. It can be very useful. You can spot masses, with an MRI, you can spot tears, but it's not the end all be all. And we know that from the research out there, 82% of people who've never had back pain have disc bulges. Roughly 45% of people who've never had hip pain or shoulder pain have labral tears, and 80-something% of people who've never had shoulder pain have rotator cuff tears. So when you have a musculoskeletal injury, think about causally, and this is the temporal portion, which, by the way, it can be a logical fallacy or it can be a useful tool. You don't assume because something happened in that timeline that that must be it. It's the combination of other factors. I've discussed it with you before. There is studies out there saying that arthroscopic knee surgery is no better than placebo for meniscus tears. That's sort of bullshit. And the reason why is because we're not deciding which type of knee pain that is. So we know a lot of people have silent meniscus tears in their knees. Say I present to the office with anterior knee pain. So on the front of the kneecap, it hurts going up and down the stairs on the front of the kneecap. I do an MRI, I have a torn meniscus. All my orthopedic tests are negative. That's probably not the reason why I have pain. Okay. Now I'm playing tennis. I turn my leg, it pops, I have swelling, I can't straighten my knee all the way, I've got a positive MRI, my orthopedist, my McMurray's is positive. Okay, that triangulation lets us know that that image is the right way, and this person probably will do very, very, very well with arthroscopic surgery. So if you did arthroscopic surgery on the other person, odds are their outcomes are probably not going to be any better because we didn't match the intervention with the right patient population. When you do, the outcomes are great. And the great thing about medicine and healthcare in general is we sort of know, at least if you're an educated healthcare professional, you sort of know what things do. And you can use those as ways to help to point you in the right direction. For example, what does spinal manipulation do? Cracking, for example. Well, it really only helps one thing, imbricated joints. If your joints are literally stuck, there's no way to unstick them except for unsticking them. But if I'm trying to treat a disc herniation with manipulation, I'm going to fail. If I'm trying to treat a muscle strain with that, I'm going to fail. And so, when all you have is a hammer, everything looks like a nail. It's important to understand what your intervention does. That way you know when and where to apply it. And I think if patients understand what each profession is sort of for, like, you don't go to the dentist to get eyeglasses, right? Like, you need to sort of have some fundamental understanding of where you're going. And then also understand the intrinsic biases within all of us. If you are and I say this all the time, if you're a massage therapist, if you go to see a massage therapist, they'll probably tell you have trigger points.
Yeah.
You see a chiropractor, they'll tell you your bones are out of place. A physical therapist, we're probably going to tell you your core is weak or you're imbalanced. You go to your family doctor, you're probably getting anti-inflammatory medications and rest. If you go to an orthopod, you're probably going to tell you something structurally is wrong that may need orthopedic intervention.
And if you go to a gynecologist,
I shouldn't be there.
and on that note, Dr. Bo. So if guys, if you're hurt, don't call Bert. Call Dr. Bo. He'll fix you up.
I know Bert.
Yeah.
Bert's a nice guy.
If you're pregnant or want to
No.
get pregnant,
I don't do babies.
Surgery.
No
And if you're in a
babies.
car accident, do not come to my office. We do not do workman's comp, personal injury, please.
yeah, he's
Oh, yeah, I gave you the wrong impression of that.
yeah. You guys are too smart
A lot
on
of
that
charting.
side.
But
I want to thank you both for coming in.
Such a pleasure.
what's
Thank
your
you.
website?
Appreciate
What?
you guys.
Website plugs.
No, she doesn't want to plug. She's too busy.
She's too
Not
busy.
like you.
Do you not have other providers that need work?
Yeah, Southwest Women's Health.
There you go. And Doctor, if you guys don't know Dr. Bo, go follow his YouTube channel.
Watch all the ads, please.
Watch the ads.
You
That's
guys
how he
gotta
gets
help me pay
paid.
for my tax bill, please.
That's how he gets
Begging
paid.
you, please.
He's got fascinating videos out there. I've even helped film some of them. So support that channel.
Please.
It's so cool.
Help me with the tax
You'll
bill.
see some really
I'm
cool
gonna start
stuff
a
out there.
GoFundMe for my tax bill.
Thanks, Doc. So really
Such a
appreciate
pleasure.
it.
Thank you.
Thank you.
Thanks for all the
you guys.
information.
Yeah. Thank you for having me.
I'm going to go take notes now.
That's a wrap.
See you guys.
Thanks.
Through these doors walk the greatest fighters in the world.